figure out that a question is moral at all. And one of the things I've realized is that often we just miss those moral moments. When I started in the consult service, we got probably about one consult a month, maybe fewer, and had for a decade. We now get 10 a week sometimes. Some of that is just sort of getting more involved and people knowing us, but some of it is teaching people to recognize moral moments, and I think that's something important for the emergency department too. The other part of this sort of moral landscape is what's now mostly called moral distress. Who's heard that term, moral distress? It's come up a bunch in the last maybe 3 or 4 years, especially in the nursing literature. The better version would be moral resolution, meaning you have a moral dilemma, you work through it, and you go home and you sleep at night. As opposed to, you have a moral dilemma, it doesn't get resolved, or worse, you feel like you know what the right thing to do, but are just totally prevented from doing it, and you go home and you don't sleep at night. That's what moral distress is about. We'll talk about that a little bit later. 4 cases. So case 1. As I said, my goal is bread and butter cases, not weird things. This is, so 50-some-year-old male comes in, unresponsive, needs to be intubated emergently in some few minutes. You don't know anything about this person, maybe you have ID, but you can't find any more information about who they are, what their medical issues are, what their wishes are, what their family is, etc. So I imagine everyone here would intubate this person, right? So the decision itself is not terribly difficult. But on what grounds? So if you were to explain to yourself and to your staff, we're intubating this person because, right, there's a clinical reason, it's fine, but the moral reason, what would you say? Okay, you would assume you would want it. I'll repeat these things because you would assume you would want it. Okay? Yeah, so you assume you would want it, and the idea is that it's a version of the reasonable person standard. That most reasonable people, common sense would tell you, if they come into the emergency department, can't speak for themselves, would want to have their life saved. And so under that is the implied consent. This is where implied consent comes from, and much of what's done in emergency medicine is under this. They may not want it. You may find out after the fact, but you wouldn't really begrudge yourself too much because it's reasonable to assume that they would, and you can't undo death. Right? If you do the wrong thing and they die, you're stuck. If you intubate, you can take it away later. That's okay. So that's the implied consent standard. But what about this? What about you go to intubate, then you open your chest and you see this. This is from the New England Journal a couple months ago, and then all the other major media outlets picked this up too. This was in Miami. They open up the chest, the shirt, and they see do not resuscitate. Would you intubate this person now?
Because he had it on file.
Does he have it on file?
He actually had it on file, yeah.
Oh, well, right. But you don't know that, though. You don't know that.
But the evidence said yes.
The evidence said yes 48 hours later.
Yeah.
So you're in the emergency department. You intubate him or not?
There's no signature.
No signature.
If he changed his mind, he could have his pets changed.
Okay.
His buddies did that as a joke.
Okay, he was drunk, right? So all these things. So in practice, so my feeling on this, and they conclude that New England Journal article with, this really doesn't help us. It muddies the water more. It doesn't really tell us whether we should or shouldn't do this because of these reasons. Well, is there actually a form out there? Was this a reasoned decision? Was he drunk? Did he change his mind and just hasn't gotten the laser tattoo removal? It's a lot easier to fill out a new, what we call Massachusetts MOLS form than it is to get his tattoo removed. All these kind of issues. So the way that I was sort of thinking through this case is that I assume that he really wants this. You know, he went to great lengths to put that there. I assume that's actually his wish. And then if you can find that paperwork, it'll in fact confirm this. But at that moment, I think you're hard pressed to follow it for that same reason. You can't undo death. So I don't know that there's a clear answer here, but I would intubate that person, knowing that I want everyone to scramble and find that form and find family and others to corroborate. And the ethical justification is this. What matters is the most proximate knowledge of the person's values and goals. You don't know that this is necessarily the most proximate. Because he might have had a conversation with the primary care doctor, a week or 2 ago. As we know, sometimes people accept more infirmity later in life than they would have thought earlier. And you want to make sure that really works. But probably is his actual wish, and I would sort of scramble to get that done. And then I would agree with that ethicist 48 hours later, but that didn't help you. So I said that you can't undo death, you intubate somebody, you can take that away. A common question that still comes up is someone says, I had an ICU attending say this to me the other day, well, I don't want to kill them. I don't want to, they've been intubated, I don't want to take this away and kill them. So what's your view on that? Is there a moral difference between not intubating them to begin with and intubating them and taking it away? Is one killing and one not killing? Right, what's the version? How do we say this?
Generally, when you're taking it away, you've got maybe a couple of days of therapy going on that hasn't gotten them off the bench, so it's a little different situation.
Okay. And what are they dying from?
His outlook may be a little worse than it was when you first intubated.
Okay. And what are they dying from? Are they dying from you taking away the tube?
Their illness.
Their illness. They're dying from their disease, their illness. So this is an important thing. This comes up with families, and I'm sure you've had this conversation. But it remains a common misconception, I think, because people feel like they're somehow actively involved in that taking away, and therefore that's killing them. But no, they're dying from their disease in either case, whether you don't do it to begin with or not. So what I've now started to translate that to when I talk to families is I say, all these things are a trial of therapy. We can try this, and we'll see. We'll reevaluate in 24, 48 hours. And if it meets the goals, great. If it doesn't, then you can take it away, and this is illness still. And so I think starting that conversation in the emergency department is a good thing, so that 24, 48 hours later, the team upstairs can start to sort this out, as opposed to like 3 weeks later or months later, when you just start going down a path that's not what you want. All right, case 2. Man comes in the emergency department with stroke-like symptoms. He's within the TPA window, no contraindications. Depending on where you practice, maybe you have a neurologist, maybe you do it on your own, maybe you have a neurologist that comes down, maybe you have to tell a neurologist. So let's say that the neurologist, via video phone or in person, says, yeah, we agree that you should give TPA, and you don't need to consent the person because TPA is standard of care. I don't know if you've heard that, but I hear that fairly often. As you can imagine, a scowl. So what do you think about that? The standard of care mean no consent is necessary. No. And why is that? How would you explain that?
To discuss the risk with the residents.
Okay. Right, you have to know what they're consenting to, that they should have a conversation about the risks and benefits. What else? But this is sort of how we explain it to ourselves and our colleagues, and why that's really important. So something can be standard of care, meaning maybe research shows it's good, the benefits generally outweigh the risks, but it may not be for this patient, because it may not match their values. Standard of care is about procedure, not about a patient. And consent is about a patient and their values. So no matter what the thing is, they have the right to decide whether that matches their life. That's the problem. So you don't want to delay, I don't want to get into a debate about TPA, but assuming you're going to do it, you don't want to be delaying. But if someone can consent, you've got to have that same conversation with them as anybody else. So informed consent, even for, quote, standard of care. Let's say instead, the patient comes in and is awake and alert, but aphasic, can't talk, can't really understand, can't really talk, you can't have a meaningful consent conversation with them, and you can't find anybody else. Would you give TPA under the implied consent? Yes. Okay. Why? Same deal as before. You assume that they would want it, right? It's a little different than the other case, with sort of intubation, resuscitation. You can't undo death. You assume they want it. Well, this, let's say that you give it under implied consent and they bleed. And maybe they're going to bleed anyway, but you now feel guilty about that and responsible because you did not have the chance to have them consent. Right? I think that remains a little bit of an open question, but it's an important one to think about. So there was a survey done. This is a neurologist in California. I think it was a sort of a national survey meant to be representative, not just of California, but of adults around the country as a whole. And he asked 2 questions. You come into the emergency department, you have a stroke, you can't speak for yourself. Would you want this TPA medication? Similarly, you come in, you have cardiac arrest, would you want CPR? What percentage of patients do you think said yes to TPA and yes to CPR, reverse yes to CPR? What would be your ballpark guess? 90% for yes TPA. Okay, how about the CPR? 10, 50, okay. It's about the same for both, 75. Right, in one study, but wow, I was like, that's interesting. So we're all pretty comfortable with the CPR, the TPA, depending on where you are, maybe, maybe not. So the one thing I think is important is that empirical data probably supports that most people would in fact want this, as your suspicion said. However, 25% is a darn large number, which I think corroborates that claim that standard of care does not equal implied consent if they can otherwise consent. All right, so the third version of the case, the patient comes in, they're more of a greater neurologic deficit, can't consent, but they have family there. So when you talk to the family, what are a couple questions that you ask them to try to decide whether or not to TPA this person?
Well, you want to find out who the power of attorney is.
Okay. Is that, so the power of attorney, that's the sort of preferred mechanism in Vermont? Is that?
So I'm in Canada.
Okay, in Canada, okay. So each state is different. The power of attorney doesn't, well, that's not true. Yeah, so the power of attorney is the preferred mechanism in Massachusetts too, called the healthcare proxy. Some places have living wills, some places have other various versions. So this person has no power of attorney completed. They have, you know, an adult daughter at the bedside and a couple other family members. What do you want to know? So if you can find that there's a decision maker, that's question number one. So great. Right. In this case, there's not. So what's next? Okay. Yeah. And have you had any conversations with them about sort of their goals and their quality of life? Have you ever encountered this before? Have they made this decision for another loved one? What did they say? Right. And try to, in the shortest amount of time, get as much information as you can. You know, consent often takes the form of, here's the procedure, here are the risks, here's the benefits, do you think they want it, yes or no, and then that's it. That's fine, but that's a little bit of a sketch, because more important than that is the things you're mentioning, is really getting into, you know, what are their preferences, what is their quality of life view, and what's the larger context. So I've now started, especially with the more invasive things, is really trying to make sure that my consent conversations are a little bit bigger than just what is this procedure, here's the risks and benefits, and do you want it. In terms of decision makers, so many states, and this is just truncated from a chart in the New England Journal starting with Maine, have a defined hierarchy for those cases where there's no appointed person, or there's a healthcare proxy. You can see that Vermont's not on here, nor is Massachusetts. I don't know the history of Vermont. Massachusetts, my understanding is that it was on purpose to make the healthcare proxy the preferred document so patients could decide who it was going to be, as opposed to some arbitrary order that may or may not have met them. Had, I think, a little bit to do with sort of, at that point there was no same-sex marriage in Massachusetts, so I think a little bit had to do with people having the right to declare anybody, if they would not have been at the time allowed by marriage to have that role. So that's why you see some of these say spouse/partner, some say spouse, etc. Massachusetts has tried to sort of get this law now in 2017. It's a little bit lumbering. So our hospital has a policy where they essentially put those in order. But what matters is the fundamental question about what the patient would want, not necessarily the who. So whether your state has a defined hierarchy, your hospital has a defined policy, if that hierarchy does not match the best sense of the patient's values, you still probably shouldn't follow it. You may have to get some other help, but you should still take a step back. All right, case 3. So this is a person that one of my colleagues told me about a couple days ago. Comes in with a dialysis fistula that's bleeding. And he puts on a bandage and then like a clamp and a bunch of other things, and it's still bleeding. Apparently to the point where he was able to take a little cup and just like catch the blood for the samples because the patient wouldn't allow an IV. And the recommendation was we should just throw a stitch in that thing because it's just going to keep bleeding. And the patient says no. But apparently the patient is able to articulate everything he said about what is wrong when the fistula is bleeding, what are the risks, you know, I'm going to die. I get that you say I'm going to die, but I don't believe you, I'm not going to die. And so apparently it was an hour or two of cajoling about this. We really did the stitch with the emergency folks, and then the vascular surgery folks, and then the psychiatry And everyone's just trying to get this guy to come around to common sense, essentially. So the question is, do you respect his wish? He says, no, I don't want this stitch. And he's like apparently watching TV and giggling. I don't want this. Do you respect that wish and let him die? Or do you somehow override that? Obviously, there's some practical implications to that. But do you somehow, from a moral perspective, override it and sedate him, or tie him down, or whatever you got to do to get this thing? And on what grounds? Well, so based on what I told you, do you think he is or not? He was able to articulate back everything he said about, the procedure and those things, except he says, no, I'm not going to die. I don't believe you. But he's able to articulate it back. So does he have the capacity to make that decision? Yeah.
What about alternatives? Did he want anything else? Would he allow pressure on it, or he just wanted to continue?
So apparently he allowed pressure, but it wasn't enough. That's my understanding.
How imminent death was he at that point?
Sounds like, that did, while in the emergency department, probably. I mean, he was just sort of continuing to swerve from one. I mean, I guess you could. I mean, you wouldn't allow an IV either. I guess you could give him back blood at the same rate he was
Can you ask him why?
I don't know. Right? So that's an important question. Let's say you ask him and you just don't get anything. He's like, I just don't want it. I just don't want it.
So he doesn't understand the consequences because he thinks he's not going to die.
Okay, great. So one of the things that was not entirely clear to me until somewhat recently is that decision-making capacity has multiple components. One of the important ones sometimes missing in patients, especially patients with mental health disorders. A mental health disorder does not make you automatically without capacity for decisions, but sometimes lack insight. So they can explain all of these things, but you really have to say, do they really have insight into that being them and appreciation of the consequences on them and that they're going to die? I mean, I've had patients, for example, up in the ICUs, they are very intelligent, tell you everything, and then you show them an MRI image and they say, oh, I get all that, but that's not me. There's still some disconnect. So making sure that insight is part of your capacity evaluation, I think in this case he did not have the capacity. And so there's some practical issues. Turns out what happened is the primary nephrologist who came down, who knew him, and said, what is wrong with you? Stop being a pain, let me do this. He said, okay, fine. Sometimes relationships matter more than anything. So this is from the New England Journal, criteria for decision-making capacity, ability to communicate a choice, understand the relevant information. This is the important one. Appreciate, have insight into, not just an intellectual understanding of the situation and the consequences, and the ability to reason through treatment options. A couple key insights about capacity that have become more clear to me over the years is there's always capacity for something. So you still constantly get that question, this person has no capacity. For what? Right? Capacity is not a global judgment. Do they have capacity to decide on what to eat? Capacity to decide on this blood pressure medicine, on this IV, on this stitch, right? They're all different decisions, and you always have to ask capacity for that decision. Right? Often the word competence too is used, and that's a legal definition. You really stick to capacity, and it's capacity for. The second is that you really need to reassess their capacity for each decision. So sometimes someone will say, well, the healthcare proxy's been invoked, they don't make any decisions anymore. Well, the reality is that they may still be able to make some decisions, and you want to give them that right, because they have it, to make the decisions that they can, and sort that out. There may be a point at which they sort of, advanced dementia, at the point where they really can't make any decisions anymore, but along that way, a whole lot of decision making was retained, and you have to assess that each time. Okay? And the final is that capacity is a matter of degree, not just in the sort of assessment itself, but in how clearly they have to demonstrate that to you. So for this case, if the risk is death, he's really got to demonstrate to you the capacity to make this decision. They're proportional. So if the risk is really high when in doubt, then I think you determine that they don't have it. Right? Again, the same thing, you can't undo death. You don't want to be wrong. Case 4. So this is a 20-something-year-old who overdoses on heroin, is given Narcan, is now in the emergency department, feels sick, starts yelling at you and says, I want to leave. And you're like, you really shouldn't leave because the Narcan may wear off before the opioids. He's like, I don't care, I'm leaving. Right? Who's experienced that? So this is a common, I think from an ethics perspective, someone will look at this and say, well, this is a conflict between two principles, autonomy and beneficence. The autonomy argument would tell you to let him make his own decision. He gets to leave, even if it's a bad decision. The beneficence argument would tell you to keep him, because you don't want him to die. It's not the worst way to frame it, but it's pretty narrow and pretty late, because there's probably other moral moments here that are important, which is why principles alone tend not to answer questions for you. And what I've started to think about more is this notion of microethics. When I said before about moral intuition and ability to recognize when a moment is moral, I think this is one of those cases. I don't know if this happens to you, but often I may not be the first person that talks to that person when they wake up. And the first person that talks to them may not have said something very nice. And one thing that you realize is that often folks with substance use disorders are very easily slighted. This is something they learn over time. And that has to do with feelings of self-worth. And a lot of times, it just does not take much to set them off, and you've already gone down that path where you're stuck with that dichotomy. But the moral moment happened the second that they woke up and what was said to them. So this is just sort of quick about why I think sort of principles fall short. But I want to take a couple quotes from a related study. This is a study from Belgium about folks with alcohol use disorders who are homeless. And it's a qualitative study, getting at what their life experience is like. And here's a couple of the things that they said. So right now I can't even think about the future. As long as there's no pain, I don't expect anything out of my life. This one's longer, I'll let you read it yourself. Okay. So what this study found is people's sense of self-worth was profoundly impaired. They felt like if they were dead, the world would be just the same. And in fact, in this particular study, about 25% of these folks were dead within a year, right? Which is far more than the folks that come with chest pain or these other things that we pay a lot of attention to. So this is a real serious thing. And so what has become clear to me is that it's our moral responsibility to actually support their self-worth from the moment that they wake up. And to have systems in place with, we have a really good sort of counselor system, et cetera. And if that's starting to get to the point where we're doing Suboxone in the emergency department, and that's, I think, going to become more and more prevalent over the next year or so, to try to get at people's feelings, their, the dope sickness, et cetera, and have a real conversation with them without any judgment. Just, okay, you're here, this is a moment, can we help you? And the sort of moral framework behind that is something called virtue ethics. And this comes all the way back to Aristotle. This is not something that's taught in medical school, but I think it's becoming, there's more and more of a place for that, because that gets you at your microethics. And for Aristotle, ethics was all about character. Habits of action and character. I think it's all those sort of little micro-ethics moments that sort of define who we are as physicians. And so what I would say is, think about all those little moments as you're thinking about ethics in the emergency department so you can be a model for your staff. I want to end with this concept of moral distress that I mentioned earlier. So the definition of moral distress is knowing the right thing to do, but being prevented from doing it by, a system that doesn't work or a quote unrealistic family. And you go home with that feeling like you're flogging someone. That's the most common version of it. When really they should just be allowed to go in peace. That's the most common version. Usually, there was a failure to sort of communicate, understand the sort of key ethical moments to work through these. And it started early, and therefore the case progressed. So part of this talk is figuring out how to understand that, but I want to explain a little bit about how moral distress works. This is quasi-empirical. But essentially, you have a case today that bugs you. Causes an acute distress, gets a little bit better after that, maybe the first night it's really hard for you, and then you start to make sense of it. But if you don't fully work that out with yourself, and more importantly with your colleagues, this is especially true in the ICU, it leaves what we call a moral residue, that sort of sense of, ooh, that just bothers me. And sometimes people feel guilty about it, they feel shameful about it, they feel like what they did was an affront to their integrity because they were doing something to this person they felt like they shouldn't, but had no way to stop. And it can lead to burnout. It can lead to anger. It can lead to just general cynicism and trouble taking care of the next patient. And then another one comes along, and you don't deal with that either, right? And it gets worse. And next month another one comes along and it gets worse. So one of the things I've now started to do as an ethics consultant is actually go around to the various units where the distress is the worst and help them process the cases over the last couple weeks or months to bring that down. And I think the same thing can be done in the emergency, okay? So that you can avoid just sort of lingering things. I'll stop there. Thanks for your time.